And we'll start with some announcements and introductions. Oops, let me stop that. First, we'll introduce the group, the Midwest Tribal Echo Group. Renee, would you mind introducing yourself again?
Oh, oopsie. Renee Folks, Indigenous Cause, Aganashimang, Zibikwe Indigenous Cause, Indigo, Zagaswa, Jamaica, Gandunjaba, Migizi, and Dudame. So it's a kind of a general introduction. My name, my English name is Renee Bolio Banks. My spirit name is River Woman. I'm from the Leech Lake Nation, and I'm from the Eagle Clan. And I've been at NACC for about a little over 5 years as an elder in residence, and I love what I do. So thank you all for joining us today. Miigwech.
Miigwech. And Dr. Ravi?
Yes, hi, my name is Kari Ravi. I'm a family practice and addiction medicine physician. I've been working at NACC since 2011, working with our MAT program since 2016.
And Nikki?
I'm Nikki Jardina. I'm the syndemic nursing supervisor at NACC, and I've been at NACC for about 7 years. And yeah, thanks for being here.
Rich, and I'm Lindsay King-Cooney. I'm the harm reduction coordinator and the Midwest Tribal Echo coordinator at NACC. I've been here a little over 2 years, and yeah, happy to be here. All right, so now I will share my screen and we'll move on to some announcements. All right, so welcome to Midwest Tribal Echo. This is the Opioid Use Disorder Education and Treatment Series. We're excited to have Ashley Brown and Audrey McGinnis from the Mayo Clinic talking to us about We Do Gagawin, a Facebook program for supporting opioid recovery among American Indian women. And this project was originally presented to us, I think, last year in the spring. So yeah, we're just really excited to hear how the program is going and hear updates today. So a little bit about NACC, you probably know, but we're FQHC. We were established in 2003, and we're located in the heart of the Minneapolis urban Indigenous community. This is a list of all of our full spectrum services that we provide, and our website is at the bottom. This is a list of current open positions at NACC. Feel free, again, the website is at the bottom to go to the job session and read more about these job descriptions. Some session guidelines, please know protected health information. If you're able to turn your camera on and willing, we love to see your faces to make connection. Please let us know who you are in the chat, and we invite you to ask questions throughout the session. This is a list of other echoes that also provide similar topics that we do on opioid use disorder. And then some announcements. We meet every first and third Wednesday of the month from noon to 1. We are no longer able to provide CMEs at this time, but we are exploring options, and hopefully we'll be able to continue that service as soon as possible. But I'll definitely keep you posted on that. And then next session will be in 2 weeks on December 18th. And then finally, case presentations. We welcome if you have a case presentation idea, feel free to email me. They make for great discussion. And with that, I'm going to stop sharing and I will hand it over to our speakers.
Hello, I'm Ashley Brown. I work at Mayo Clinic. I've been there for about 14 years, and I've been on Dr. Christi Patten's team in the behavioral health research program for the last about 3 years. So Audrey, if you want to introduce yourself.
Yeah, hi everyone. I'm Audrey McGinnis. I'm also working with Dr. Christi Patten at Mayo Clinic in the behavioral health research lab. I'm fairly new. I've only been with the department for about 6 months, so still very excited to be involved in all the work going on in there.
All right, so I will share my screen here. I don't know about anybody else, but it's very, very windy where I am at. So I apologize if my internet is like glitchy or anything like that. It might be kind of slow. But crossing our fingers and hope it works great. So yes, thank you again very much for letting us be here and to chat about our study. We really love our study, so anytime we get a chance to talk about it, we like to do so. Okay, so Widokage win. Excuse me, let me move this. This means the place for help. Let's see if that will move. The place for help, the time of helping in Ojibwe, and a local Native elder woman actually named the study that was recommended to us by the CAC, the Community Advisory Committee. And the study logo and artwork were designed by an Ojibwe artist, Selena Downwind Jubera, and it is reflecting joy and strengths of Native women in community to support opioid recovery. And there are no disclosures or conflicts of interest to report. Here are some of the co-investigators that we work with. As you can see, they're listed in different places, but our study is done in Minnesota. But some of the investigators from many other clinical trial network nodes bring their expertise to the project. So we really appreciate having them on our study. So a little bit of the study overview. During AIM-1, it took about 18 months from start to finish to do AIM-1. That is where we had our Community Advisory Committee and Healthy Nations Advisory Board. They co-designed the protocol and the intervention. So we started with the qualitative work where we had 14 Native women in recovery and then 12 interested parties. All did some qualitative interviews for us to start this out. And then from there in AIM-1, we did our beta test with 10 Native women in recovery. And the study importance is, of course, reducing opioid use. It was a need identified by the Native communities in Minnesota. So this was a study that was brought to us, which was a big thing for Dr. Patten and the investigators, knowing that it was a need. And it was a need because programs developed specifically for Native women do not exist. So this was something very important. And it was also developed with partners at the Minnesota Indian Women's Resource Center. So from AIM-1 brings us to AIM-2, which we are currently in. That is the pilot RCT, and this is to evaluate the feasibility and preliminary efficacy. And then, of course, future plans being effectiveness of trial expanding to other clinical trial network sites. So the qualitative interviews, these were done, like I mentioned, with 14 Native women. The average age was about 36, and the opioid abstinence average was about 6.5 months. And then we also had 12 interested parties that did these interviews for us, and some of those roles were people such as healthcare providers, clinicians, social workers, advocates, things like that. So what we did was we rated videos and text postings for cultural relevance and perceived effectiveness. And then this is just a little word cloud that includes participant responses to what is one word you would use to describe what you think of this Facebook group. So I thought that was nice to see some of the pride, hope, community, strength, some of those really important words. And then some Native words that were put in there too had meanings like warrior woman, to seek what is cherished but hidden, the way of the heart in medicine. And actually one Native woman participant stated, just to let them know there is people that did go through it, they're still here, they made it, that there's hope, there is help, and you don't have to be embarrassed. So some themes based on the content analysis. These were the biggest ones to highlight: the reconnection to culture being very important for recovery. Media and text should resonate with the AIA and culture and strengths. And we want to maintain confidentiality and build that trust. So we really want to tap into positivity and positive memories. Participants liked the gratitude posts with native imagery because both are prevalent in the AIAN culture. And so really tapping into that native resilience was shown to be important. So the study population, this is our eligibility criteria that we have. Identifying as an American Indian or Alaska Native woman, being 18 years or older, living in Minnesota, meeting the criteria for the opioid use disorder, and that's based off of a DSM-5 checklist. Current use of medication for OUD. That seems to be one that, at least from what I can remember back with like screening, that would often be one of the most common ones as to why women weren't eligible, is because they weren't on OUD medication. And then they have to have access to broadband internet on a device and either have a Facebook account or be willing to create a Facebook account. I think we've helped 2 women create a Facebook account, so they were very open to it and it was fairly easy to do. They had to be willing to travel to the Indian Health Board clinic in Minneapolis for their urine drug screens. Very, very grateful for them for their use of their facility. And then they have to report 1 month or more of opioid abstinence based on a timeline follow back interview and self-report. So that includes that negative urine drug screen on their baseline. And we recruited from Native community clinics and organizations in Minneapolis and St. Paul. So here is a little example of a post in the beta test Facebook group. So this is for the intervention. This Facebook group encourages acceptance and peer-based social supporting. So we want to address the role of stress and trauma in substance use. We're using evidence-based content, mindfulness-based relapse prevention practices in daily life and high-risk situations to prevent return to use. We're using SMART, the Stress Management and Resiliency Training Program, online landing page of local cultural and community resources to support recovery, videos, native artwork, photographs, text posts and poetry, and then really focusing on that positivity, self-care, and again, that cultural reconnection, like we talked about those 3 bullet points. And we developed the content library of postings. We worked really closely with the Community Advisory Committee to make that content library. And then, like I mentioned, this is one of the examples where it has, that quiet moment of gratitude, and then the artwork from Christi Belcourt. So this is a pretty good example of what we use. During the beta test, they were also posting once a day and really trying to encourage conversation. So for the moderator exchange, during the beta test, Karina, who is out right now, and Antonia were the main moderators for that. Myself and Audrey were not, I was just beginning to be a part of that, but Audrey wasn't with us yet. So they were the main moderators for there, and now it's been myself and Audrey moderating the Facebook group that we're doing now, but then also 2 Native elders. And then again, these were the training topics that we all, as moderators, went through. We made sure to do training with various different people, like motivational interviewing. We had someone here at Mayo Clinic who does some moderator exchanges on some Facebook groups. So we wanted to make sure that we were all knowledgeable in the area of how to get that deep meaning from people, how to get that engagement the best way possible for the group. So for the 30-day beta test, we had 10 AIAN women. The average age was 42 years old in the group, and then they had an average of 15.2 months of opioid recovery. 30% in the group reported other substance use. So other substance use doesn't make them ineligible for the group. So the surveys and the urine drug screen were done at the baseline when they signed up for the study, and then at the end of the intervention. And during their baseline, when we were meeting with them at the Indian Health Board, we were giving them a journal and then a little smudge kit as kind of like a welcome gift, but also in hopes to use that journal maybe during the Facebook if they needed to do some gratitude or, you know, anything like that, but then to use on their own, of course, as well. So this was the welcome posting that was done to start the group off. And that was done by Antonia, as you can see. So another good example of what we try to keep our posts like. So let's see, intervention uptake. So the participants engaged, meaning they viewed, reacted, you know, they liked or they posted or they commented or voted. I know sometimes we'll do polls, an average of 33 times. 90% commented or reacted at least once. Engagement trended higher in the last 10 days of the beta test, which just goes to show that relationship and that rapport building is very important. Moderator and participant posts elicited similar engagement. And then the most frequently discussed topics were managing opioid recovery, that interconnectedness, and then change. So with the follow-up survey, this was done after everybody was finished. There was 9 out of 10 for 90% retention. There was the usefulness, satisfaction, and ease of use scale that we had in there. They rated spirituality a 9.25 out of 10, which I thought was pretty good. And they all wanted the group to last longer. So that was definitely a good sign too. And then community partner feedback. The findings are relevant and impactful for the urban Native community in Minnesota. Unanimous interest in being a peer moderator speaks to the acceptability of the intervention. That was a question that was asked in, I believe, the end of intervention survey where, you know, would you be willing or interested in, you know, being a peer moderator in another group? And a lot of people were interested in that. So I thought that spoke volumes. Their intervention could be an effective tool for patients who want continued social support as an adjunct to clinic treatment program. I think it's really great to have this along with, you know, any kind of support groups or counseling that they might have, with that being, you know, usually scheduled on days and times and things like that. This was something where they could just jump in when they need it. And so I think that was really important. Caring about each other's recovery story could improve self-esteem, reconnection to culture again, being a very important component in recovery, and the appeal of the study to younger women, less than 24 years, and helpful to work with a trusted community partner for conducting the urine drug screens and the other assessments. Again, the Indian Health Board, I want to say very, very grateful for them. So yeah, it just overall the intervention addressed and expressed community need, and knowing that it was co-designed with Native women and interested parties was really good, and just really reinforcing that reconnection to culture and having trusted community partners.
All right, thank you, Ashley. I'm going to take it from here and just sort of like give everybody an idea of where the study is at now after all that background, all that work that we've done to get up to this point. So what we're looking at right now is just kind of a little flow chart that we actually do present to our participants to kind of give them an idea of what they're signing up for when they consent to our study. So the first step is right now we've actually started doing a Qualtrics screening survey, more on that in a little bit. But once they've gotten in contact with us, we do a phone call with them to sort of get more information, make sure that they're eligible, tell them a little bit more about what the study will be like. After that, they sign a consent form for us, and then they complete a urine drug screen either in person at IHB or over Zoom to make sure that they are testing negative for opioids and positive for that MAUD, that medication use. After that, they are randomized either to the intervention group or the control group. So if they're in the intervention group, then they are in that Facebook group, and that is meant to support them in their recovery from their opioid use disorder. And if they're in the control group, they don't get that Facebook group, but they do get a resource guide. So both groups get that resource guide, but only the intervention group is in the Facebook group. Although we do actually offer the control participants, once their sort of like time in the study is up, if they are interested in receiving that Facebook intervention, that is something that we offer them, just for sort of equity reasons and ethical reasons. And then throughout their time in the Facebook group, they will complete 2 additional UDSs for us just to sort of check in on how they're doing with sobriety, and the results of those tests don't do anything. They don't get kicked out of the study. They don't get rewarded or punished based on their results. It's really just sort of for us to measure that. And we try to be very clear with our participants about that, because we know that there can be a lot of anxiety around drug testing. And they also complete some surveys where they talk about sort of their identity, their engagement with the Facebook group if they're in the intervention group, and their drug use throughout the course of the study. So here's our current numbers. Our recruitment, or our accrual goal, is a total of 60 women, and we currently have 18 who are fully accrued and either at the beginning or have already completed, they're somewhere along that kind of route of this intervention period. So obviously we're not quite up to our accrual goal yet. That is something that we're actively working on, and doing presentations like this one is one way that we're trying to get the word out and hopefully get those accrual numbers up. But yeah, if you kind of follow the numbers along here, I feel like the biggest kind of drop off point is from screening to consenting. It's pretty common in studies where people will say, hey, this looks cool, but then once we actually hand them the big long form and they have to do the signature, it can be a little intimidating, or they decide, actually, I don't have the capacity to do this right now. And so some people will drop off there. And then we only had a handful of people who either did not complete the required baseline UDS or tested positive for fentanyl and then had to be dropped, and were unable to move forward. So the good news is that when people do consent, they seem to pretty much follow through and maintain that involvement with us, which is great to see. So over the past year or so, several months that we've been doing this phase of the study, we've had to put through a few modifications, because studies on paper in protocols seem all great, but then once you actually get into it and you're working with participants, there are hiccups, and so that's why we have mods. So one of our first modifications that we did was to add the option for UDSs to be done over Zoom. So this remote option is where we mail at-home test kits, which is actually the same kit that we use ourselves. It's a very simple, it's kind of like a COVID test, so it's a very doable, people are familiar with how these tests work. So we mail those out to our participants, and then we set up a Zoom call with them where we sort of guide them through how they do the UDS, how to read the results, and then they give us, they show us their test cards and we see what the results were. And this was really done to increase accessibility for people and our range of recruitment, where now we can have someone like in Duluth participate, because we're not going to be asking them to drive several hours down to IHB at least 3 times to do their UDS visit. So that really improved the kind of range that we really now can recruit for the whole state, which is what we really wanted to be doing. And since this mod has gone through and was approved, we've had lots and lots of participants opt for this remote option. In fact, I think the majority of them have been since it was approved, even though they have to sign a reconsent for it. This is like very accepted by the participants. They're really eager to not have to make that drive or get on that bus. So I'm really glad that we had that option for them. And it's given us a lot more flexibility with scheduling too, because I am actually located up in the cities and I'm the only team member who is. So before I joined, our other study team members were having to drive like 2-3 hours round trip to do these UDSs, which made it pretty limited to fit in with other meetings. But now that it can be over Zoom, pretty easy to fit those meetings in. Our other modification was a mod to our Facebook content. We were just kind of seeing like low engagement, which can be explained by the fact that we only have 9 people in that intervention group, and that's a very small group to try and get real engagement going. But there was also some kind of like discomfort among us as moderators about the tone. It didn't feel very genuine, felt kind of too robotic, and it didn't really feel like we were creating genuine connection. So we wanted to add in some new posts that had more genuine language and add a little bit of structure to the content so that it felt both more intentional and more genuine at the same time. And we really wanted to focus our new posts on building community, getting those conversations going, because, you can put up a post that is asking a very personal question, but if we haven't done the base work of just sort of like, this is me, who are you, people aren't necessarily going to engage in that. So we wanted to add in a little bit more community building. And since then, there's still been some challenges. We still only have a handful of people in the group. Engagement is still sometimes challenging, but we have seen an improvement, I would say, since we've pushed that mod through. And then our most recent modification, this is very recent, was we updated our social media ads. So we edited the language in our recruitment ads, hoping to reach more participants, just again, made it a little bit more genuine, a little bit more friendly. And we also added a Qualtrics survey, which I think this is a new mod, but I'm willing to bet it's going to make a pretty big difference. Originally, our ads would just give the phone number and our email and say, hey, if you're interested, reach out. But that's kind of a big burden to place on our participants and their busy, busy lives. So we replaced that with a Qualtrics survey so that they can just click a link. Then that way, all their contact information is there available for us, and we can do the work of reaching out to them. So we're really hoping that we'll be able to stay in contact with more participants that way and kind of reduce that initial burden of getting people involved. So we are still facing some challenges. Studies are always in flux. There's always hiccups that come up. Our probably biggest challenges are low engagement and low recruitment, which I've already talked about a little bit. But in trying to think through, why are these things happening and what can we do about them? When it comes to low engagement, as I've mentioned, we don't have many members in the group, and that makes it challenging to really have a lot of engagement. But also, we've found as moderators, it's really challenging to stay within the approved content. We have a content library that's approved. That's all that we should be pulling from. But sometimes we really just want to post something that we feel, oh, this is exactly what the group needs to hear right now, or this would, foster a lot of connection, but we can't do that without having it basically vetted by the IRB and ethics boards. So there is sort of that necessary barrier there. It's there for a good reason, but it also does make it hard to get that engagement going sometimes. So what we're trying to do about that is we've introduced live events every once in a while. We've only had one so far, and only one participant showed up, but it was wonderful. It was just we were just there hanging out, talking, and it was a very genuine, connected moment. It was really great. And then she actually was engaging a little bit more in the group after we had that little chat with her. So we saw that make a difference in engagement. So we're hoping to make that a regular thing. And again, just very, very casual. We're not trying to have discussion topics or guide the session. We just want to sit in community with these people so that there's more trust and community being built. And then they might be more likely to feel comfortable coming into the Facebook group to talk about their lives. We're also continuing to go through our new content from the modification. So as that kind of gets in the mix more, we're hoping engagement will go up. And of course, recruiting, if we get more members in there, our engagement will go up. So we're improving our recruitment efforts as well, which brings us to our factors for why we're struggling with recruitment. I think a really big one is there's a cultural distrust in Mayo Clinic, which is completely reasonable. Mayo does not have a very good history in how we've engaged with Native populations, especially when it comes to research. So there's some very, very understandable hesitancy among this community when it comes to choosing to be involved with Mayo Clinic in a research capacity. And there's also just, these people are marginalized population, they're struggling with substance use, there's a lot going on in their lives. So they might just not have the time, the energy, the capacity to say, yeah, I'm gonna do a research study right now. They just might not have those resources to engage with us. And that's, again, completely understandable. So what we're trying to do about that, recognizing that those issues are going to remain, and there's, we can do what we can to build trust, but there will always be that sort of cultural divide. We are updating our ads. We've added that screening survey, just hoping to make more connections and be more genuine upfront and build that trust from, step one. And we're also working to reconnect with our community partners to try and get the word out through fellow community members and again, just build that trust. So part of our more updated recruitment efforts is I went around and posted flyers in a lot of community kind of centers around the Minneapolis and St. Paul area. So hopefully seeing those flyers out in the community, people will feel comfortable coming to us knowing that it was approved by a community partner. And more recently, we've also given flyers to some of our participants who asked us if they could post them. And so now there's some flyers in places that we would never even have access to, like people's apartment buildings. And, you know, people are spreading the word, our participants are spreading the word as well, which is really, really great to see. And I think has already made a bit of a difference in how many people are coming to us. And also presentations like this one are a big part of recruitment. We're just kind of getting the word out there about what we're doing and hoping that that will increase recruitment, increase engagement, just awareness of the work that we're doing. And we're just overall working really hard to connect with new community organizations and community partners, as well as our existing partners for this project. So if you guys know anyone, have any ideas about how we can get the word out, have any ideas about how we could improve the intervention or recruitment, anything like that, we're so eager to hear advice, input, anything that you can share with us, help us out, would be much appreciated. Thank you so much.
Thank you so much. Do you mind turning off the slideshow and then we can see people's faces and see if people have questions or comments? Thank you. There is a question in the chat. Would it be okay if to let various folks in the Duluth area know about this amazing intervention?
Yeah, absolutely. We have one participant, I believe she's in Duluth, in the Duluth area, who has joined, and yeah, absolutely. We can send out whoever would like. We do have flyers. I could either mail them to you so that they're printed, ready to go. I can email them to you. We have two different kinds of flyers. One that's just the flyer with all the information, but then we also have one that has little tabs at the bottom, so they can rip off information if they need to bring it with them. So yeah.
Yeah, that would be great, because right now, I mean, obviously we're based in Rochester and Minneapolis, so our places where we can physically post flyers are currently fairly limited. So if, you know, people here are spread out more around the whole state, we can absolutely email you our flyers, both kinds, and you know, they're IRB approved, so they're good to print and post. That would probably make a really big difference actually in our recruiting efforts. So that would be fantastic.
Yeah, so Jean, I have your email. I'll send it out.
I do have a few questions. This sounds like such a great idea, and I just have some questions about, like, in terms of like privacy. Like, people are joining with their own Facebook profiles? Is that right?
Yep. Yep.
And then then you can see in somebody's Facebook profile what groups they're in, right?
This is actually private, so other people cannot see the group. The only way that anyone would know about the group is if they were invited to it.
Okay. And then, so that was the first question. And the second question, just some questions around like including people in the group. So, in terms of ongoing use or relapse, if they're getting checked, if the urines are getting checked, what happens if they come up positive?
So it depends on what is positive. So I would say a common one is being positive for THC. So that nothing happens with that. So they still get the payment for doing the drug screen. Pretty much all we do is we note it. So we put that down on our forms. But I guess really honestly, anything that they test positive for, they still stay in the group. You know, everything pretty much goes the same. It's just that we record what's positive and what's not.
So in terms of if they were positive, they don't have to leave the group. It's recorded, but they stay in the group, but it affects the study, but it doesn't affect the person.
Correct. Yep. And usually when I'm meeting with the person, I don't know about other people, but I just really try to encourage to use the Facebook for support and the resources. I'll ask questions, do you feel like you have the resources you need? Things like that, but definitely get to stay in the group.
And then so far, are you seeing high rates of abstinence, or are you seeing a fair amount of use?
I would say at the beginning, it's been kind of spread out with, you know, when people have enrolled and their timeline and time frame of what they're doing things. At the beginning, I think I was seeing a lot more abstinence, but now I've seen maybe a little bit more of some use. So
I'm just wondering if people are not coming in for testing because they're, or, you know, they don't want to feel the shame, you know, especially if they're feeling visible.
mhm,
And like even the initial test, the initial cohort, like the fentanyl stays in the system for a really long time.
mhm.
So wondering if that's not impacting sort of people's engagement, is that sort of feeling like they're being measured and that they even if there's not a real a visible consequence, that internal feeling of like, now I'm seen, you know.
Absolutely. Yeah, I would agree with that. And I think because I have seen one for sure, maybe two that I can think of, participants who we actually lost track of them doing their UDS. So they did their baseline and they followed up. So they get their surveys, you know, every month. So month 1 through 6, and then the baseline 3-month and 6-month UDS. And the participant can continue to do all of the surveys, but she wouldn't connect with us to get that urine drug screen done. So I would agree with you that I think sometimes that's a barrier.
I wonder if there's just a way to make it feel less shaming, and you know, like to sort of have more somewhat of a harm reduction approach where you just really talk, you know, we understand recovery is not always, you know, a straight line. You know, relapse can sometimes be a part of recovery. Just to like at the outset, you know, we want to see you regardless of whether you really very explicitly sort of make some statements that make people feel safe in having their use be so visible in an environment where being absent is a requirement, be there.
Mhm. Yeah, I really like, and I wonder too, we actually, Audrey and I were just meeting before this, discussing some things, and we were gonna maybe do another modification for more content for our Facebook, to include some holiday times and sobriety. So maybe that could be something we include in our modification, is a post that speaks to that. I think that would be a good idea.
Yeah, I would agree. I mean, we do like when we see people for those UDSs, if something is positive, we always, you know, have a conversation with them about it. Because I mean, I've had it happen where they're like, I tested positive for benzos. Like, I've never taken those. Why is this positive? And so sometimes it's a very confusing thing and they can be kind of alarmed. And we sort of talk through like why that might be positive. And, you know, it's okay if you don't know, like, you know, nothing, there are no negative consequences for you about this. But yeah, we have conversations with them in the moment. And I think we do try our best to make it clear up front that, you know, there are no consequences for them in this study if they are positive at any point. But I think that that's definitely something to keep in mind. I do think it's probably a deterrent to people being comfortable engaging with us. And I think maybe actually even in our modification, maybe changing our flyers, changing our ad language in some way to just make it like really, really explicit and say positive tests are inconsequential for, you know, your participation in the studies.
Well, I think it's also like at our clinic, you know, if somebody has a positive test and they come in, you know, we're like, wow, you know, you still showed up, you're still engaged,
Right.
you know, you're you know, like it's not, it does like, I think that like if you have a 12-step model, it's like once you've used, then you have to restart your sober date again and everything. You know what I mean? If you can kind of sort of like reinforce, you had an episode of use, but you're still engaging, you know, like really make it into you can make it a positive. I wonder if that just, and to just, yes, and to think about your materials all in that scope.
Yeah, I think that's a great idea. I think, yeah, Ashley, you and I can maybe take a look at all our content, see where we can add in that positive framing of that. Thank you. That's really helpful.
Harm reduction language can be very helpful and kind of,
Absolutely.
I just had a question. I'm not sure if you covered what the incentives are for the participants. What the amount is, and is it like a Visa gift card or?
Yep, so we were doing cash cards where we would have to mail them or give them if they're on site, of course. A $25 gift card for every survey that they do, and then a $50 gift card for every UDS that they complete. Again, regardless of what the results are, they get that. And then we have oh gosh, time is all going together. 6 months or so, we've been using the Clin card. So then it's something that we can send them, and it's that reloadable debit card. So they can just keep that, and then I can reload money onto it in 5 minutes, which is kind of nice. So then they get that money. Then they're not waiting for it in the mail, which is kind of nice.
Are you also testing for BUP when you do the UTOXs?
Yep,
And those
Yep.
are positive?
yep. Yeah, those have to be positive on baseline as well, but yeah.
But as you move forward, are they continuing to be positive?
Yes.
Yep.
I would say the majority of people that I've seen, I have not yet had a participant be positive for opioids, and all of mine have been positive for BUP or the other
BUP.
mouth slipping my mind right now.
Right. But even if, I guess, you know, if they were negative, which I agree, I haven't seen that yet. Again, they would still be in the group.
Yeah.
Yeah.
There's another comment in the chat. Love this intervention study and the use of artwork and culture. Is there any chance this would open up nationally to tribal MAT programs who can assist with substance testing and patient participation virtually?
Yeah, I think that that's kind of, you know, when we talk about at the beginning, the aim 1 being complete, aim 2, and then the future plans, that's kind of what we're hoping for. So depending on how this aim 2 goes for the clinical trial, that would definitely be a possibility, I would say. It's a hope.
Also,
Hi. Oh, sorry.
Oh, go ahead, Tanya.
Okay. Hi, I'm Tanya Cherland. I was on one of the panel at the Mayo Tribal IRB Summit that you held. I think it was in 2023. And I know myself and the other panel participants had been administrators of tribal institutional review boards or had been involved in developing tribal IRBs. And we stated at that time that it was really important to honor tribal sovereignty and to seek tribal nation approval if you're recruiting for research on their lands. So one concern I have, and I'm wondering how you're addressing this, is that 2 tribes in Minnesota have tribal IRBs, and they have policies or codes that prevent you from recruiting on their lands without approval from their IRBs. And if you're going to think about scaling this up nationally, that would also apply. Many tribes have IRBs now. And so even though recruitment is being done through social media, people living on those reservation lands have a right to have their tribal IRB review the research. So I'm wondering how this project is respecting tribal sovereignty, first of all. And then my second idea is that if you continue to have problems with recruitment and engagement, I wonder if you would consider subcontracting this research, developing partnerships with urban Indian health programs to actually do the research themselves because they have that background and that experience to be culturally safe and to know of all the nuances that might come up surrounding this research. And at the same time, it would be building research capacity where oftentimes it hasn't historically been supported. Thank you.
Yeah, those are very good questions and thoughts about it too. So some of them I don't have answers to. So I'll have to talk to Dr. Patten, and I can definitely reach out to you and let you know. What I do know is with some other studies that we work on in Alaska, we work with the Alaska IRB pretty closely. So I think that it's a great point that, you know, if we did go nationally or spread out more, that would definitely have to happen. But for the other questions, I apologize. I don't know, but I can definitely get those answers and get back to you.
That's good. You should know that many of those tribes do have like tribal laws against recruiting on their lands. So you might want to be aware of that from a legal standpoint, but also from a health equity standpoint, because it is challenging tribal sovereignty to be recruiting on social media on their lands. And they might even be able to provide you with support in a way that could really benefit the research study and improve the work that you're doing. So there are you know, not just sort of that back protection aspect, but also the aspect where they can improve the quality of the study itself through that type level of engagement. Thank you for listening. Thank you for considering.
Thank you
Yeah.
very much. I appreciate that.
No, I really appreciate you bringing that up because I think it would be I mean, like you said, not only from like a legal standpoint, but also from like health equity and just improving the study overall. I think that more direct partnership, other than just sort of like, hey, we want your input, like directly partnering with IRBs for those nations, I think would make a big difference in the quality of the study and in the trust within the community if they can see, you know, this is approved by my tribe, you know, that I think that's a great idea. That's something we should probably, Ashley, I think maybe make a note, you know, we can have conversations about that with Dr. Patten and with kind of our other study team members, because I think that's a really important part. Yeah, and in terms of subcontracting, I think that was also something that another community partner had sort of brought up, is more directly and involving in an official capacity. Some, you know, other community partners, I think a limitation to that would probably be our budget. But again, something that Ashley and I can't speak directly on, but I think it is something we should definitely bring up to Dr. Patten and see if that would be a possibility. Yeah, thank you so much, Tanya.
Thank you, Tanya. I can make sure to get the three of you connected and with Christi as well, so that you can continue the conversation there.
Perfect. Thank you so much.
Yeah. Does anybody have any other comments? There's a comment in the chat that says, I love that the testing was addressed. Harm reduction will encourage commitment for sure.
And I see someone also mentioned Memory Keepers Medical Discovery Team in Duluth. That is not someone, to my knowledge, that we've partnered with, but definitely a group to keep in mind as we're moving forward and trying to reach out to new community partners. So thank you for that.
Yeah, I worked with them for 6 months, and a lot of, like, I worked as a qualitative analyst, and a lot of the interviews we saw were elders saying, like, I'm dealing with memory loss and I'm raising my grandchildren because my children are addicted to substances. So you know, I'm sure they would love to work with that. Yeah, feel free to reach out. I have contacts from working there, but if you you can probably cold email them too. They're really nice.
Yeah, if you could, maybe if you want to put your email, you can put it in chat or direct message it to me or Ashley. We can make a note of that and get connected with you to get connected to them. That'd be great.
Yeah, I work for the Department of Health in North Dakota now, so that's why my email might not be there.
Got
but
you. Okay. Thank you.
Does this study have a projected end date, or how far along are you specifically? I'm sorry if you went over that.
No, that's okay. We are trying to enroll 60 people. So as of right now, we're going for that.
Got it.
And then of course, once we would get our last person, it would be 6 months. Since the intervention is 6 months, then it would be 6 months after the last person enrolls. But yeah.
Well, great. I'm happy to share flyers if you have flyers for the program, and connect you with everybody that was here today. Is it okay to share your slides with the group?
Absolutely. Yeah.
Okay, great.
Yeah, and for the people who put their emails in chat requesting flyers, I've got your emails down. I'll be sending those out to you.
Yes.
All right, well, thank you so much. Thanks for your presentation, and yeah, thank you everyone for joining today. I hope you have a great rest of your day, and we will see you hopefully on the 18th of December. Thanks, everyone.